Friends, good evening. I'm Dr. Ashutosh Gupta, and I'm a consultant fetal medicine. So today we're going to talk about a bowel dilatation, right? So this bowel, the fetal bowel और जो आंतें होती हैं उनको दो तरह से हम डिवाइड कर सकते हैं, small intestines and the large intestines. So when we identified that the colon is dilated, right? So we can have some 3 to 4 more differential diagnosis. So we try to see for the target sign, which is called as an anal pit. So what we can see is this, that the hyperechogenic mucosa is there, anal mucosa is there, and surrounded by a hypoechoic muscularis, right? So but then this target sign, it is not a sort of a sacrosanct for an high anal atresia, that once we see this target sign, so probably we have ruled out the high anal atresia, but it is just a supportive one of the important parameters and landmarks, and a supportive sort of an evidence was to see that probably we are just ruling out an high anal atresia. Secondly, we can see the dilatation of the colon with fecalith. So marble types and the fecalith, they get all segregated all throughout the colon, and therefore that these two findings they might sign across to an high anal atresia, right? And second could be an Hirschsprung's disease. Now the Hirschsprung disease is this, in which we do have some issues with the ganglionic sort of a segregation in the muscles of the colon or in the bowel. So a ganglionic segment जो होती है तो collapse कर जाती है, and the ganglionic segments proximal to it gets dilated. So it usually goes from distal to proximal. तो anal pit से होते हुए या रेक्टम से sigmoid colon से होते हुए वो descending colon ऊपर आती है. So it goes distal to proximal, right? So that is what it is. And the third part, it could be in ileal atresia. So ileal is usually small intestine obstruction, and we can have a multiple fluid levels. We can have a vigorous peristalsis, and the obstructive lesions are entirely mechanical obstruction. The ultrasound picture is absolutely different from what we are just going to discuss now. So we are going to discuss a finding called as a paralytic ileus. So paralytic ileus is non-obstructive, and then the bowel is all dilated. We don't have any obstruction, but the harbinger and the pathognomic sign is this, that you don't have any peristalsis, and then if you once you keep the baby under observation, you don't see the passage of the meconium in the bowel, and then we don't have any hostile movement or peristalsis in the small intestines, and the hostile movement in the large intestine. So let us first go through these videos, and then we'll talk about all these things in detail. इसको देखिए ध्यान से. So probably what we can see कि sigmoid colon is all dilated. So we can see the meconium lying in between, but we don't have any movement. And the higher upper limit is 19 millimeter, but we identified it to be 12 millimeters. So and, not that great. And this is the rectum, which is hugely dilated. Okay. And then what we were trying to now look around for is the anal pit, and we could identify the anal pit very well. So this is the hyper. So gut signature is there. So the hyperechogenic anal mucosa is definitely there, surrounded by the hyperechoic muscularis. So anal pit is absolutely looked around wonderfully well, and then we go back again, and then we try to look around. The rectum is hugely dilated. Similarly, the sigmoid colon, we go to the descending colon. So this is the sigmoid. So rectum, sigmoid, and then this is the transverse colon, which is dilated. The conspicuous and the pathognomic finding is this, that we hardly see the movement of the meconium. There is no hostile movements, and there is no peristalsis, right? And we are just trying to shake up the baby, and so this is, and then we saw the baby on 2 occasions, and we identified the findings are almost the same, and this is the large bowel descending colon, right? So this is the sigmoid, and overlying is this. So we don't see any movement of the meconium in between, and no peristalsis. So gut is lying listless, absolutely. So this is again we are focusing on to the so rectum, and that was the anal pit, and then the sigmoid colon, right? So that is what it is. So this looks like to be paralytic ileus. Then we went back into the history to that lady to ask what exactly is happening to her, and then we identified that she is under influence of a beta agonist, right? So a dilated bowel loops, but no or absent peristalsis, and mechanical obstruction is entirely different, in which we can have a volvulus, multiple fluid levels, and but you do have a progressive sort of an polyhydramnios, and you can have a progressive movement. Isoxazoline is the culprit. So 20 to 30 milligram per day, and magnesium sulfate can also lead to, if it is in prolonged this thing. So drug dosage is the exposure, the duration is more important. So beta agonist is this thing, and we identified it to be reversible. Fetal medicine is just like jigsaw puzzle. So there are a lot of differentials, and probably whatever is the finding that is available on the ultrasound, so we have to just solve that puzzle, right? So no fecalith, anal pit looks around good, so that probably ruled out high anal atresia. It is not a picture for high anal atresia. Response because rectum is usually dilated. We don't believe that probably it would be it is falling into that Hirschsprung thing. It is not a classical picture for an illegal atresia. Illegal atresia is entirely different shoes. Liger was also, it was not polyhydramnios. And the drug history was very, very pertinent that probably she was on a slightly high doses of azathioprine, right? So there is no, so beta agonist, some people they've identified it to be sensitive to beta agonist. It is azathioprine is a non-selective beta agonist, and usually 10 to 20 milligram per kg, 10 to 20 milligram OD or BD TDS is the usual dosage that we give. She was taking some high doses. If it is greater than 20 to 30 milligram per day, so probably we can identify it to be drug-induced paralytic ileus. Secondly, magnesium sulfate can also be culprit, but usually the magnesium sulfate has been given for the IV loading dose, like 4 milligram to be given IV and within an hour, within 2 hours or so. So the loading doses they really don't lead to this paralytic ileus. Magnesium sulfate for neuroprotection has been given for a prolonged period and therefore can lead to this sort of a clinical picture. But isoxazoline or beta 2 agonist are the commonest drug culprit for this paralytic ileus to the baby, and therefore we what we did is this, that we followed the baby out across for 2 days. We identified that still the baby is under the sort of an exposure to that particular drug, even though we identify that the T half is only for 12 hours as is supreme, but probably it will take. So mid gestation it is about the exposure, it is not about the dosage, it is not about the target dose that probably somebody would have at the exposure to, but it is the duration and mid gestation, and then it falls into this drug induced paralytic ileus. So we are not having any mechanical obstruction. We believe as the drug would wash off from the mother as well as from the fetus, the prognosis would be excellent, but we are just waiting for that peristalsis to reappear again, right? So that is how it is. So this is a wonderful case, and really a lot of insights for us. So as to identify, so the drug can also drug induced paralytic ileus can also be there. That is how it is. Thank you very much for your patience.